Greetings. Hopefully you enjoyed our ad. This is, if you were able to see the video that played just before we started, this is our video that's on local media and part of our Mental Health Month campaign that we'll be using probably throughout the year. So this is our last presentation. Oh, hold on a second. All right. You can move a slide, Brian. This is our last presentation in Mental Health Month, and so we want to remind everyone about mental health awareness. This Friday we have a drive-through Mental Health Awareness Month activity here at the Health and Wellness Center, where individuals can drive through and get a resource kit, and we have those available in English, Spanish, and Hmong. And so that's advertised on our social media pages, and I encourage all of you to share widely. I also want to remind you that on Friday is the deadline for nominations where you can nominate fellow county employees for living the guiding principles. So the Guiding Principles in Action Awards, we've gotten quite a few nominations thus far, and a reminder that everyone who got nominated will be acknowledged, and then we'll have a drawing for some special prizes to further honor those who were nominated for Guiding Principles in Action. That's our Mental Health Month activities. So quickly, COVID by the numbers in the world. As of today, we have 5.6 million cases and 300 and almost 52,000 deaths. And then in the United States, it's 1.68 million, so we're approaching 1.7 million cases, and just under 100,000 deaths, a little over 99,000 deaths. So you might hear in the media about the 100,000 deaths, 100,000 lives. In California, we went from almost 82,000 cases last week to 94,558. And 3,334 deaths last week to 3,795. And I'm sure you've been hearing that incidence of cases and deaths has plateaued somewhat, and in some cases is declining in California. And that's why the governor and many local municipalities are moving forward more aggressively, I think, through the stages of reopening that we went over a couple of weeks ago. Even a couple of weeks ago, we talked about being in stage 2, and we're already where some stage 3 businesses are reopening, like nail salons and such, and restaurants are starting to reopen. I know last night when I picked up my takeout, it was a little jarring to see individuals eating in the restaurant I went to. I haven't seen that in a while. And so you'll start to see those activities. I think, I mentioned this last week, a lot of divisiveness right now and a lot of differing opinions on the safety of reopening, and I just want to continue to reiterate that our willingness to follow the precautions, to wear the face mask, to keep the physical distancing, washing our hands and such, really is our hope to live with COVID and not experience incidents of COVID or deaths beyond what we would expect. And so that's got to be our mantra. COVID's still here, it's still with us. We have to keep acting like that. In Fresno County, we're up to 1,535 cases and 26 deaths. So we have had an increase in deaths. A reminder about those deaths, and I'm going to go to the next slide and talk about a little more about these deaths. Each week I try and add a little different flavor to the information I'm providing. And so what you'll see on the Fresno County website, it's a special COVID-19 section, and if you click on the information portal, you get the information from the last slide, and then you can look at the top and there's some surveillance tabs you can hit, and this is one of them. And it really talks about what are the demographics of the people who've died in Fresno County. And so you'll see that there have been no deaths in the 0 to 44 age range in Fresno County, 3 from the ages of 45 to 64, and of those 3, all 3 had comorbidities. And then if you go up to 65 to 74, 6 deaths, 6 with comorbidities, and then over 75 comprise 11 of the deaths. And this only shows 20 of the deaths, and I'll talk about that in a minute. And 8 of those 11 deaths over the age of 75 had comorbidities. So some had no known comorbidities. So definitely what we're experiencing in terms of the age of the population is similar to what's been experienced in other parts of the United States and the world, and that is the preponderance of deaths are in the upper age ranges, although there definitely have been deaths in the lower age ranges, but at a smaller incidence. And with only 26 deaths in Fresno County, you may not see the whole representation of the impact of COVID. And then I'll just mention that a lot of the information about deaths we're getting the information past the time the person died. So the cases get reported pretty much in real time. So each day there's a report out on the number of lab tests that have been received that were positive. But the deaths, someone could die today and it might take a week or more for the coroner to establish that they died of COVID. And if you look on this website, it specifically says that a confirmed case requires detection in a clinical specimen. And so if a person doesn't have that, I don't think they're calling it a COVID death. There's a lot of information in media right now about, if you had a car accident and a positive COVID death, they would call it COVID. I can tell you 100% that's not what's happening in Fresno County, and I think that's actually fake news. But that's the kind of information you'll hear, and I think that it is important to note, I think I said this last week, a lot of viruses do not themselves cause death, but the complications of that virus cause death. And so when a person has underlying health conditions, does it make them more vulnerable? Of course it does, but that doesn't mean that they would not, that means, in my opinion, that they would not have necessarily died had it not been for COVID, even though they had underlying health conditions. And then the second table here is by race, ethnicity, and comorbidities. And so in terms of race and ethnicity, there have been we don't have the information on the number, but of the individuals who were Black who died, 100% of them had comorbidities, and the case fatality rate is 3.23. And so mortality per 100,000 persons is 2.17 for Black. For Hispanic, about 78.5% of the individuals who died had comorbidities. For a case fatality rate of 1.84, but a mortality per 100,000 persons of 2.63, which is actually the highest mortality rate of any ethnicity in our county. And then 100% of the individuals who were white and died had comorbidities for a case fatality rate of 2.54. And the case fatality rate has to do with the fatality rate of the fatalities in our county. And then mortality per 100,000 persons is 1.73. So definitely people of color have a higher mortality rate than white individuals. And so this is consistent with what we know about COVID in other parts of the country. So what about testing? I keep getting asked questions about testing, so I decided this week I would focus a little more on testing to help you understand some of the nuances. The diagnostic or PCR test is something that tests for active COVID. So if you hear PCR test, that's to test for someone who actively is producing COVID in their body. They're active with COVID. And this is the swab test, the one that has the really long swab that you have to put really far back in your nose, that at least my kids swear they're never going to do that test. It is used for, the swab is for mucus. That's why they stick it so far back in your nose. They are investigating it for saliva to see if they could do the PCR test with saliva, so a closer, not having to stick it so far back. It is pretty reliable, but if you do the test too early after exposure, there may not be enough COVID in your system for it to be detected using that test. It has to be administered properly. If you don't get it far enough back, you may not collect enough of a sample in order to detect COVID. And the turnaround time is, I said, increasing. It's actually improving. And what I mean by that is we're getting shorter and shorter times to get those test results back. And that's largely a function of having adequate, what's called viral transport media, having enough machines to do the test and enough capacity within those machines to accommodate the volume of testing that's happening. And then there's another type of diagnostic test called an antigen test. And this also tests for active COVID. It is using nose and throat secretions, so very similar to a rapid strep test, where you get results in minutes, but it is not as accurate as the PCR, so right now they're looking at it more for screening. So if an individual comes into a doctor's office, for instance, with symptoms, and they've done a flu test and that's negative, maybe they've done a strep, whatever, they could do a rapid test and that might direct them to order the PCR test. So it has a role, but it's not necessarily as good as the PCR test. And one of the things that's debated as well is what does the test really do for you? And mostly what it does is it helps differentiate what your diagnosis might be, but the treatment doesn't necessarily change. If you end up in the hospital, they're going to test you for COVID for sure, 100%. And there are some different treatments now that are coming about for COVID, whether it's prone positioning. There's some medications like remdesivir that was developed for Ebola that is showing some promise. Some of the blood plasma from individuals who've recovered from COVID is showing some promise. So if you know you have COVID in the hospital, that's going to help direct them how they might treat you a little differently than if they're not sure what you had or they thought you had something else. In an outpatient setting, it might not do really change, although it might kind of calm someone's mind to at least know what they have. So that's the diagnostic testing. Then there's the antibody test, and I often get asked about this as well. This is the one we don't really have a large prevalence of in our county. And this identifies people who previously had COVID. So they no longer have active COVID. They now have produced enough antibodies to show that they had COVID and have recovered. This is a blood test. You get the results pretty quickly. It is less reliable. And one of the reasons it's less reliable is we're so early in the process. There's a lot of talk about a vaccine as well, and people hear 12 to 18 months. They can't believe it takes that long. Well, it can take a while to develop these tests to diagnose as well as to develop antibody tests. And the FDA has relaxed some of the rigor, the scientific rigor around these tests because of the need to really understand better what the prevalence of COVID is or the prevalence of people who've had COVID in our population as we race to develop that vaccine and a better understanding of whether or not we've developed immunity. So when you relax those regulations, you end up with more tests available but less accuracy typically because they haven't been through all of the scientific rigor. And then there's kind of an interesting phenomenon with these types of tests. We know that, let's say you hear that a test is 90% accurate. That sounds pretty good, but that means 10% of the time it's going to give you a false positive or a false negative. And you might be willing to go with a 90% test, but the problem is when you're testing antibodies, until you get to enough prevalence in the population, the false negatives or positives are higher than the prevalence. So it will misrepresent what the prevalence of the antibodies is in the community. So when you only have 3 to 5% prevalence, you might do the antibody test and think you have 10% prevalence. Now you've told people who actually don't have antibodies that they do, and they might behave recklessly, or you've told people who do have antibodies that they don't. And so we just have to be cautious with the use of the antibody test until we get a higher prevalence of recovery from COVID in our population. It's going to be difficult for us to rely on any antibody test because of this kind of anomaly about the low population prevalence. The other thing to know about antibody tests, they don't show up in your body for several days to a couple of weeks after infection. So if you just had COVID, or you aren't sure you've had COVID, but you think you might have, you could have an antibody test. It could accurately show you do not have antibodies, but you still could have had COVID. So you have to wait a little while to get an accurate test. And because we know that some people are asymptomatic and never have symptoms of COVID, it's another reason why you just have to be cautious about relying on antibody tests. Because how would you know that you tested far enough past COVID if you never had symptoms? And then the other thing, and this is really frustrating, is immunity isn't insured. So we don't know yet if you can reacquire COVID-19 after you've had it. And just as an example, and we're all learning as we go through this, common colds, when you get a virus that causes the common cold, you're typically immune from catching that same exact cold virus, and there's lots of them, but only for a few weeks. So you could have a cold, recover, have the antibodies, but they only last about a few weeks, and then you could get the same virus again. There's other things like chickenpox that once you've had it, you have immunity for many years and sometimes for your whole lifetime. And so that's just differences with different types of viruses, that just because you've had it, there's no assurance that you're going to keep that immunity for any period of time. And a lot of colds are from other versions of coronaviruses, and that's why scientists are really watching closely to understand better, will you have immunity? Will you be protected from getting COVID again simply by virtue of having COVID before? One thing, and I didn't put this down here, but I'm beginning to hear, is that they don't really think at this point that COVID-19 mutates like the flu does. So right now, the way we do flu vaccines every year is it's a different vaccine every year. That's why you get a different vaccine, because there's prevalence of different types of flu viruses that they watch very closely through epidemiology surveillance across the world. But also there's mutations that happen in flu viruses where you have to have a slightly different vaccine each time the virus mutates. They're not seeing that right now with COVID-19. That's not to say they won't find out later that it mutates. But right now, when they're examining from the past several months, they're not seeing the types of mutating that would make them think that they would have to develop multiple types of vaccines in the future. So cross your fingers on that one. All right, so that's my spiel on testing. Someone asked me last week, how do you find out all this information from reliable sources? And I'm sure there's some people who think I'm not reliable, but I'm kind of a voracious reader, and I get a weekly report from the Journal of American Medical Association that I tend to comb through. And then typically if I read it in some sort of media source, and I tend to read all kinds of media sources, I will kind of research and see. One of the frustrating things right now for scientists is, and I talked about this last week a little bit, this concept of misinformation versus lack of information. So misinformation would be providing false information as opposed to doing the best you can with the information you have and updating it when you learn more. And really that's what science is all about. You're constantly studying things, and as you learn more, you might change your recommendation or your observations, etc. And so a lot of scientists right now are frustrated with the concept that they're perceived to be unreliable because the recommendations might change. But this is a brand new virus, and so it's gonna change. We did not know as much about COVID-19 a couple of months ago as we do now. And then the other thing is, a lot of the science research that's being done right now typically the way it works is you would not even see that research until it had been vetted through a rigorous scientific validation process. Sometimes other studies would have to be done supporting or refuting the findings. It's reviewed in certain journal publications. It has to go through a review process where they look at the scientific method, how many subjects, how the subjects were chosen, all the different things to ensure that it was valid science that was done. And nowadays, because of the desire to rush to treatment and rush to vaccine, some of the research is getting published, if you will, in non-traditional ways. So not in established medical journals that have went through that scientific validity and rigor process, but it's just getting posted on blogs and chat boards and ways that scientists are communicating with themselves, but then someone takes it and tweets it, and it's published as if it's truth when it really hasn't went through validity. So you have to be careful when you're reading different things and just recognize that it's kind of the Wild West out there right now, and you have to really look at things with a little bit of scrutiny and really look at the resources of where you're getting that information. All right, in terms of what we're doing, we continue to go through a fairly methodical process for how we will return people to work. Right now, it's looking like starting as early as next week, we might dip our toe into the water, if you will, of slowly bringing a small number of people back in a really structured way where we're kind of tracking it closely, starting in the next week or two, we'll say. And I can quickly review the kinds of things we're looking at, everything from general considerations, when you'll wear a mask, signage, infection control practices broadly throughout all of our buildings, HEPA air filters in our HVAC systems and such, and looking at all the workstations for do they have the proper distancing, putting the plexiglass up, I mentioned the signage for distancing and such. And then really looking at individual areas and making sure there's not too many people crammed into an area. Once we understand how many workstations in each area are safe, then we'll put some thought into, okay, maybe you can bring a bunch of people back and they can individually work, but would it be too many people for the common spaces? And so you should expect over the next few weeks to be really flexible. We'll start small, where either if there's an area where it's a relatively small number of people, we might start bringing people back to that area. Where there's a larger number of people, we might do rotations, where you come back to work a couple days a week and work from home on the other days. And then the other thing I will tell you is that likely it'll be the administrative staff that comes back first. The clinical areas are going to take a little more strategic thinking and some work because typically the areas where individuals receive therapy are small, and you have 2 people in an area together for therapy. And that's probably the highest risk environment for acquiring COVID, and that is 2 people being within 6 feet of one another for over 15 minutes unprotected. Now, we could protect people, but we'll likely only gradually move to that. So telehealth and telework, you should expect to continue well into June, and possibly for some areas or individuals longer than that. And so again, I would ask for your patience, your flexibility, your understanding that we're working really, really hard to create safe workspaces for you and the people we serve. We want to do it methodically, carefully, slowly, to ensure that each measure we put into place is working before we add more people into the mix. We'll also be watching closely what's happening with COVID cases in our community, and if we learn additional information about that or we see a surge in cases, we might have to adjust our plans with that. So this is a time where if you don't like uncertainty or instability, it's going to be uncomfortable for you, because it's just going to take time to get back to what used to be our normal, and it may not happen for a lot longer. And so I'm just going to have to ask for your patience and your understanding as we carefully navigate through that period of time. And so I have on the slide still through May 31st. I'm going to be putting a little more formal thing together, but I'm telling you today that most of you will continue working from home at least part-time, at least for the next couple of weeks, and some of you for even longer. Okay, I'm ready for questions. Brian,
Yes.
do we have any questions?
Yes, we do.
Okay.
Is it possible to allow us to take time during our workday to get COVID tested without having to use annual leave hours?
There's a question about whether it's available to take time during the workday to get COVID tested without using hours. This is a hard one for me because there are many options for getting COVID tested. Certainly, if you were having symptoms, we'd want you to go home and see your doctor or do whatever you needed to do. So I wouldn't envision that being work hours. So I would just say, please talk to your supervisor and help us understand why that would be necessary.
Where can I go to get tested?
Right now, the easiest way for you to get tested, if you don't want to go to your healthcare provider, is there are 2 sites that are run by a company called Optum. One is at Fresno City College, and the other one is in Sanger. And you can go online and sign up to get tested. There is some impact right now, especially to the Fresno City College site, where it may be a little harder to get an appointment, might take you a few days to get that appointment. It's my understanding that Sanger has a lot more flexibility, so if you're willing to drive to Sanger, that's an easier place to get tested.
When we return to work, will we be given N95 masks?
This is a question: when we return to work, will we be given N95 masks? N95 masks are utilized in clinical settings where a healthcare provider is in close contact with an individual at high risk for exposure. So right now in the hospital setting, just to give you an example, the average clinical person in a hospital setting is using a surgical mask, and the N95 masks are being utilized when you're caring for someone with COVID, when you're engaged in a medical procedure where there's a high risk of what's called aerosolizing. It's either an aerosolizing procedure, you're intubating someone, you're giving them a breathing treatment, or you have to be within 6 feet of that person where they're not masked. And so somehow in our community, we've decided that if you don't have an N95, you're not safe. If you're coming back to work and you're going to be working in close proximity to clients, giving a medication injection, taking a lab draw, or if we get to the point where people are in close proximity, likely you will be given an N95 mask. We're looking at protocols for things like if someone needs to drive someone in a car, where we might modify how the car is configured or put protocols in place for masking requirements of both the person being transported as well as the driver. And so we're looking at those types of things. N95 masks are not required outside of the settings I've described, and they're also still in short supply. And so even over the last several weeks, if you were an entity and said, even though I'm not doing the things that an N95 mask is required, I'm going to order them, the government would seize your shipment to preserve it for hospitals. So that's kind of where we're at right now. Every employee, when they come back to work, is going to be given 2 cloth masks for their use. And that is going to be our standard when you're not in a clinical area and not delivering clinical care.
Do we have a suggestion box employees can express concerns or ideas?
We don't have a suggestion box. We do have a compliance hotline, so you're always welcome to put something there, or there may be some other. Brian, are you aware of any suggestion box?
No.
My hope would be, maybe it's idealistic, that you wouldn't feel the need to anonymously express a concern. I think you've seen over the last several weeks, I'm happy to take any question. And so if you have a legitimate concern, I would really hope you would feel comfortable taking it to your supervisor, a coworker, or take it up the chain of command, because we want you to feel safe here. This is a really scary time, and I'm not going to presume that every single person has the same standard for what it's going to take for them to feel safe, but we will work with you to try and answer any questions that you have.
When will reassignments for clinicians become available?
This was a question, when will reassignments for clinicians become available? I would have to defer to Susan Holt on that one, and so I will ask her to put out something in the next few days about that.
Is there an update regarding a timeline for hiring unlicensed clinicians?
The same thing in terms of hiring unlicensed clinicians. What I would tell you is we did put forward a priority recruitment to Human Resources, which was approved, but I don't recall exactly where unlicensed clinicians was on that. So again, we'll get something out in the next day or two about that as well.
If we are anticipating pay reductions considering state budget cuts, when might that be implemented for DBH?
This was a question about if we are anticipating pay reductions because the state is contemplating pay reductions, when would we hear that? That would be a process we'd have to go through, including the county overall would have to work with our labor groups, labor partners. And so I wouldn't anticipate a decision being made on something like that anytime in the immediate future, but I would anticipate if that does get considered that it would be part of the budget development process, which will be happening over the next few months.
And as another related question, is DBH looking at layoffs or furloughs for workers? How are we financially?
This question was, is DBH looking at layoffs or furloughs for workers? How are we doing financially? I did share last week, and I encourage you, if you didn't watch the presentation last week, I shared some of the behavioral health impacts of the May revised budget that the governor produced last week. We are finishing up our fiscal year in June and starting another fiscal year. It does look like the revenue sources for most of our funding are anticipating a decline that will impact us over the next few years. And so we will be, as we develop our budget over the next couple of months, we will be looking at all of our options in terms of how we will sustain through that period of time. We are in a good financial position as a department. We do have some reserves. And so we'll be looking at what we can do to preserve the services that we provide to the people we serve. And as we know more about how that might impact all of you, we'll certainly share that with you.
Okay. If we need to wear personal protective equipment in the hot, can we please turn on the air conditioning? It is so hot in there, I actually got sick from the heat.
Okay. This was a question about if we are required to wear face masks in our work setting, and in particular at the Health and Wellness Center, can we have air conditioning? Of course you can have air conditioning. It was hot in my part of the building too. I would also encourage you to let facilities know if there's a heat problem in your area, and we'll work to address that. We had a really hot set of offices in the administrative area, and facilities got on it, and in one day it was addressed. And so the other thing I would say though is we're not anticipating for most of the workstations where we bring people back to work that you would be required to wear your face mask at your workstation. And what I mean by that is the recommendation to wear your face mask is really related to your ability to physically be distant from other people. We know, again, that when you're in close proximity to someone who has COVID for more than 15 minutes, you're at higher risk for getting it when neither of you is wearing a face mask. So we wouldn't anticipate putting two people working side by side closer than 6 feet in a situation that would require them to wear a face mask the entire time they were here. What we're anticipating in the non-clinical areas is that the face mask recommendation would be when you're in common areas, which would include coming and going from the building, going into break rooms, walking down the hallway, going to the bathroom. In clinical areas, it's a little more challenging. If you're in a private office by yourself, you don't have to wear a face mask. But if you're in constant close proximity to people, you might have to wear a face mask all day. We're looking at some tools that make the face mask a little more comfortable to wear that we're hoping to acquire for staff. And you know what I would say is it's not fun for me either, but just keep in mind that we have healthcare workers each and every day as part of their job that are wearing it 10 and 12 hours a day. And so we just have to think of that if you're going to be in a high-risk situation, that's when you really need to wear it. If you're able to have that physical distancing, and particularly with physical barriers like walls or partitions or things like that, then it becomes less imperative that you have that face mask on.
What will the process be for staff with underlying health conditions to return to work?
This question was about the process for individuals with underlying health conditions to return to work. We continue to anticipate at this time that we'll try as much as possible to continue telework for individuals at high risk, and you will need to work closely with your supervisor and human resources on that.
Okay. For people who have children or at-risk family member, will we be able to work from home longer?
This question was for people who have children and maybe don't have they didn't say this, but childcare or daycare services, or have an at-risk family member, could they work from home longer? Again, I would encourage you to talk to your supervisor in human resources and explore options. We will attempt as much as possible to preserve telework in certain circumstances, but that needs to be worked through with your supervisor and human resources.
Okay. The rest of the questions are very similar to those. So.
There are some other questions on the chat that seem very similar to ones we've already answered. We'll give it a minute or two just to see if any other newer questions come up. I do want to reiterate, each time we get these questions, it reminds me that this is a scary time for all of you. And, I just want to continue to give you my reassurance that we're all working very hard, those of us who are coming to work, to explore the very best options to create safe workspaces. And when we're not able to create a safe workspace, we're not going to bring you back. And if there's high-risk needs and such, we're going to try as much as possible to incorporate that into our planning and accommodate for that. We did get some additional telework type equipment, laptops that are equipped with internet and microphones and cameras and such that we hope will allow us to extend telework where we need to. But the other thing I want to remind you is if you have a job that we are unable to assess your effectiveness and efficiency at working from home, it's going to be very difficult for us to continue telework at home. So it's really important that the work that gets done is the type of work that we can assess the effectiveness of that job being done. And I want to reiterate this as well because I've heard reports of this. If you're working from home and your supervisor attempts to contact you and is unable to do so, you will not be paid for working that day. It is your responsibility when you're working from home to be available to your supervisor. If you're involved with a client or on a priority call, you can send a text, you can send an email, etc. If you're not able to do that, I would expect when you see that there was an attempt to contact you, that you make every attempt as quickly as possible to get back to your supervisor. This is what will allow us to continue telework where it's necessary. If we're unable to get in touch with employees, if we can't tell if work's getting done, we simply can't allow telework to continue. That's just the reality. And so our ability to assess the effectiveness of the work getting done is vitally important to the desire to continue telework. And so that's something that's important for you to keep in mind and for you to be accountable to your supervisor, to be available to their needs when they are attempting to contact you. So I want to make that clear. We've put it in writing. I've said it here a couple of times. Do not be surprised if you are unable to be reached. You will not get paid for that day. That will have to be leave time.
The last question is pretty much what you just talked about, so I think we're good.
Okay. Thank you, guys, and we'll see you in June.